We're doing a Euromigos Goes to Hollywood video on Enfortumab Vedotin Pembrolizumab and its recent FDA accelerated approval in frontline cisplatin ineligible urothelial cancer. It's got a response rate of 68% in 120 patients. PFS in those two cohorts about 12 months, OS 24 months. Gem-carbo, its comparator, previous trials, 45%, 6-month PFS, 12 months OS. It looks better in indirect comparisons. You've got the luxury of using this in the United States. Which patients are you going to choose in Enfortumab Vedotin and Pembrolizumab instead of chemotherapy followed by maintenance of avelumab? Because it's not just chemotherapy that's the comparator anymore, it's chemotherapy and maintenance of avelumab.
So I think it's a sort of a no-brainer that if you have a cis-ineligible to give Pembro IV instead of carbogem. But obviously patients come with comorbidities. So if someone comes with ulcerative colitis, autoimmune disease, or already underlying neuropathy from their diabetes, maybe Pembro IV is not going to be the right combination for those patients. But I don't see why not to use it.
So complete change
otherwise.
for you. Complete change. 100% of patients. This is a landmark moment. For the first time in after 40 years, we've got a new treatment of bladder cancer in UCLA.
Yeah, I think.
And all your patients, and what about those cisplatin eligible? Because it's always PS1, PS1.5, PS2. You can always. Is there going to be that creep?
We have seen
that
some
Gamsky criteria creep.
Well, look, we have seen some durable, amazing responses with Pembro IV through the studies that we ran. So I'm pretty convinced that that will be a way to start. Cis-ineligible. For cis-eligible, I want to see the data from the registrational study that is not out yet.
Are you comfortable with the toxicity profile to change because you've got a 63% grade 3 or 4 adverse event profile. You're going to make a whole scale change, frontline bladder cancer of 120 patients.
I think cisgem is more predictable and carbogem more predictable, and we're confident how to treat the toxicity. Pembro IV has a little bit more room, and we have treated many patients who have seen almost all the side effects, but on an 80-year-old probably will be easy, short and sweet to give the traditional chemo.
Gem-carbo's got 60% grade 3 and 4 adverse. Chemotherapy is not easy to give either.
But it's maybe easier when you talk about Pembro IV skin toxicity that, has been pretty significant. So if you ask...
But that skin toxicity is in the first couple of cycles, and it either happens and it's traumatic, which you stop the drug, but it's about education. I guess it's the same as neutropenia was when we first used cisplatin.
Yeah.
The first, oh my God, I got neutropenic, and we realised we had to be really careful about that, and the same about renal impairment with cisplatin. I mean, these drugs are all hard to give. None of them are a walk in the park, and I think that for me, the combination with all of these drugs, sacituzumab govitecan, Enfortumab Vedotin, urothelial, all of these drugs are challenging to give. We don't have easy drugs in urothelial cancer, but gem-cis, gem-carbo for 6 cycles is pretty hard work. The question I'm interested in is how many cycles you'd want to give, and whether or not you just keep going to progression or whether you modify.
I think for the Pembro IV,
yes.
So I think all depends on the tolerability. If they start developing neuropathy early on, you have to start doing some dose reductions. So I think at some point you have to stop your EV and just continue with your Pembro. It will be similar to your maintenance.
What's your take, Brian?
I don't think I would make a whole-scale change. It's certainly more aggressive. I view it as more toxic therapy, but if you can compare across trials, a higher response rate, right?
Yeah.
So if you have patients with visceral disease and bone disease and something like that, you might say, well, gee, I'll take the 70% response rate at the cost of that toxicity. But it's hard to argue. I mean, chemo followed by maintenance of avelumab has level 1 evidence of a survival advantage, right? And so I think this is very appealing and shiny, and the response rate's high, but I don't think it's going to be as simple as a whole-scale switch. And obviously we need randomized data. I think it's more interesting in a cis-eligible population, right? Where you're fit to get cis or you're fit to get EV Pembro. To me, that's going to be a more clinically relevant question.
For me, we're primed for this really promising combination, which is going to change. I think it will change everything if it hits this big survival advantage against standard of care in EV302. And I think the tolerability profile is manageable, and I suspect the grade 3 or 4 adverse events will be the same as chemotherapy in both arms. I don't think it's going to be different. In Europe, clearly, we're going to wait for that survival advantage, and it's going to be really important. And I think we have been premature with even the FDA, dare I say it, has been premature giving approvals in urothelial cancer before. We've got the pembrolizumab story, we've got the atezolizumab story. They've had to change their minds twice. But I think this is different. You remember those single agent immune therapies, response rates were in the 20s and 30%, and we were sort of hoping for this halo, long-term, durable, and as it turned out, the chemotherapy arm was working better than we expected, the biomarker didn't work, and that story. But I think this is different. When you're seeing response rates of 68, 70%, it's going to be very hard for that not to beat chemotherapy in the end.
And actually responders, you can give them a good break. So I have a patient who's like 2 years on a break and there is no progression. There are people with liver mets, bone mets. All you need is a few cycles to control the disease and then...
And that'll be important. I mean, like
Yeah.
our IO-TKI regimens in kidney, not necessarily treating everybody with a doublet forever.
Yeah.
That doesn't really make sense. It won't be tolerated. So I think those strategies will need to develop.
So to wrap this up, chemotherapy is going to be, with avelumab, is going to be a standard care in much of the world for at least until that randomized phase 3 reads out. But actually, the US seems to be relatively comfortable about grabbing this promising data from 120 patients and waiting for that randomized to reinforce that signal. So thank you very much indeed. I hope that went well.